Welcome to Roadmap to Residency. Today we are diving into chest pain evaluation for Step 2 clinical knowledge, with a focus on acute coronary syndrome. This video is designed to help you master the test-taking strategies you will need to tackle these high-yield questions. We will work through real board-style questions together, and I will show you exactly how to approach each STEM. Remember, this is not about memorizing everything. It is about pattern recognition and knowing how to eliminate wrong answers. For the full foundational knowledge, make sure you are reviewing your core Step 2 resources like First Aid and UWorld. Let us get started. Before we jump into questions, let us quickly review the learning objectives. First, you will master test-taking strategies specific to chest pain questions using pattern recognition and elimination techniques. Second, you will learn to differentiate between ST elevation myocardial infarction, non-ST elevation myocardial infarction, and unstable angina based on electrocardiogram findings and troponin levels. Third, you will apply risk stratification tools and management algorithms to confidently select the correct answer. For a deep dive into the pathophysiology and complete management, refer to your cardiology chapters in First Aid for Step 2 clinical knowledge and the UWorld explanations. Here is the first framework you need to internalize. Acute coronary syndrome exists on a spectrum, and the board exams love testing whether you can distinguish between these three entities. On the left, we have electrocardiogram findings. ST elevation. Myocardial infarction shows ST elevation in contiguous leads or new left bundle branch block. Non-ST elevation. Myocardial infarction and unstable angina both show ST depression, T-wave inversions, or can even have a normal electrocardiogram. On the right, we have troponin levels. This is the key differentiator. ST elevation, myocardial infarction, has elevated troponins, but you never wait for them before treating. Non-ST elevation. Myocardial infarction has elevated troponins, and this is what separates it from unstable angina. Unstable angina has normal troponins because no myocardial necrosis has occurred yet. Lock this framework in your mind. Now let us talk buzzwords. When you see these combinations in a question STEM, your brain should immediately jump to the diagnosis. For ST elevation myocardial infarction, think crushing substernal chest pain plus ST elevation in contiguous leads plus new left bundle branch block. For non-ST elevation myocardial infarction, think chest pain at rest, plus elevated troponin, plus ST depression, or T-wave inversions. For unstable angina, think new onset angina, or accelerating angina, plus normal troponin, plus normal or non-specific electrocardiogram changes. These patterns will appear again and again on your exam. Let us work through our first case together. Read this STEM carefully. A 62-year-old man with diabetes and hypertension presents with severe substernal chest pressure radiating to his left arm. It started 45 minutes ago. He is diaphoretic and nauseated. The electrocardiogram shows ST elevation in leads V1 through V4 with reciprocal ST depression in leads 2, 3, and a VF. Before I reveal the answer, think about what the question is really asking. What is the diagnosis, and what is the most appropriate next step? Let us break this down systematically. First, recognize the pattern. This is a classic ST elevation myocardial infarction presentation. Substernal pressure, radiation, diaphoresis, ST elevation in V1 through V4, which means anterior wall involvement, and reciprocal changes that confirm acute ischemia. Symptoms started less than 90 minutes ago, so time is muscle. Now eliminate wrong answers. A is wrong because we never wait for troponin in ST elevation myocardial infarction. The electrocardiogram is diagnostic. D is wrong because stress testing is absolutely contraindicated in acute myocardial infarction. B, thrombolytics, would only be correct if percutaneous coronary intervention is unavailable. The correct answer is C. Emergent percutaneous coronary intervention is the gold standard for ST elevation myocardial infarction when available within 90 minutes. This is called primary percutaneous coronary intervention and is superior to thrombolytics. Here is our second case. A 58-year-old woman with hyperlipidemia presents with 2 hours of chest discomfort at rest. She describes pressure that radiates to her jaw. Her electrocardiogram shows ST depression in leads V4 through V6 and T-wave inversions. Initial troponin is elevated at 0.5 nanograms per milliliter. Pay close attention to the troponin level mentioned in the STEM. What is the diagnosis and what is the next step? Let us work through this. First, identify the diagnosis. This is non-ST elevation myocardial infarction because she has ischemic symptoms, ST depression with T-wave inversions on electrocardiogram, and elevated troponin. Remember, if troponin were normal, this would be unstable angina instead. Now apply the management algorithm. The correct answer is B, non-ST elevation. Myocardial infarction does not require immediate catheterization like ST elevation myocardial infarction does. Start dual antiplatelet therapy plus anticoagulation and plan for an early invasive strategy within 24 to 48 hours. C is wrong because thrombolytics are never used in non-ST elevation acute coronary syndrome. D is wrong because discharge is inappropriate for acute myocardial infarction. Now let us cover some management pearls that appear frequently on Step 2. For initial medical therapy in all acute coronary syndrome, remember Mona B. Morphine if needed for pain, oxygen only if saturation is less than 90%, nitroglycerin unless there is a right ventricular infarct or hypertension, aspirin immediately, and beta blocker if no contraindications exist. For key time-based decisions, ST elevation. Myocardial infarction needs door-to-balloon time under 90 minutes for percutaneous coronary intervention, or door-to-needle time under 30 minutes for thrombolytics if percutaneous coronary intervention is unavailable. Non-ST elevation. Myocardial infarction gets early invasive strategy within 24 to 48 hours. Board exams love asking about these time thresholds. Case 3 tests a subtle but critical distinction. A 70-year-old man with known coronary artery disease presents with chest pain at rest that lasted 20 minutes and resolved with sublingual nitroglycerin. His electrocardiogram shows non-specific ST changes. Serial troponins at 0 and 6 hours are both within normal limits. What is the diagnosis? Think carefully about what differentiates unstable angina from non-ST elevation myocardial infarction. Here is the test-taking strategy for this question type. The only difference between unstable angina and non-ST elevation myocardial infarction is troponin elevation. Both can have identical symptoms and identical electrocardiogram findings. Serial negative troponins means no myocardial necrosis, which means unstable angina. Let us go through each answer. A is wrong because there is no ST elevation described. B is wrong because troponins are normal, so no myocardial necrosis occurred. D is wrong because stable angina is predictable with exertion, but this patient had rest pain, which is an unstable pattern. The correct answer is C, unstable angina. Case 4 is a classic board question about choosing between thrombolytics and percutaneous coronary intervention. A 55-year-old man in a rural hospital presents with crushing chest pain. The electrocardiogram shows ST elevation in leads 2, 3, and a VF, indicating an inferior wall myocardial infarction. Symptoms started 60 minutes ago. The nearest catheterization lab is 2 hours away. His blood pressure is stable at 140/90, and he has no contraindications to anticoagulation. What do you do? Let us calculate the timeline. First medical contact to balloon time would exceed 120 minutes. Symptoms started 60 minutes ago. Transfer takes 2 hours, plus you need time for catheterization lab activation. This far exceeds the 90-minute target. Now apply the decision rule. If percutaneous coronary intervention cannot be achieved within 120 minutes of first medical contact, thrombolytics should be given if no contraindications exist. This patient has no contraindications described. The correct answer is B. Give thrombolytics now, then transfer for rescue percutaneous coronary intervention if needed, or routine angiography. Remember, never wait for troponins in ST elevation myocardial infarction, and heparin alone is insufficient for reperfusion. Our final case tests your knowledge of contraindications. A 68-year-old man presents with ST elevation myocardial infarction. The nearest catheterization lab is 3 hours away, but here is the key detail. He had a hemorrhagic stroke 2 months ago. What is your management? You must know the absolute contraindications to thrombolytics for the exam. These include any prior intracranial hemorrhage ever, ischemic stroke within 3 months, suspected aortic dissection, active bleeding, and significant head trauma within 3 months. Now apply this to our case. The correct answer is B. Prior hemorrhagic stroke is an absolute contraindication to thrombolytics, regardless of when it occurred. Even if percutaneous coronary intervention takes longer, it is the only reperfusion option for this patient. This is a must-know concept for boards. Make sure you review the complete list of thrombolytic contraindications in your cardiology resources. Thanks for watching. If you found this helpful, please like and subscribe. And if you are looking for expert tutoring or residency advising, visit us at roadmaptoresidency.com. Good luck on your exam.